So, yes. So our next speaker is Associate Professor Lim Sung Yoon. So he's a pulmonary and critical care medicine specialist at Seoul National University at Bundang Hospital, South Korea. I had the pleasure of working with Dr. Sung Yoon in one of our projects, which was the ASAP ECMO study. So essentially, the ASAP ECMO study is a multinational PK study of several antibiotics and antifungals in critically ill patients receiving ECMO. But Dr. Sun Yun, unfortunately, can't be with us online with us. So, but he did send his recorded presentations.
Good afternoon. My name is Sung Lim, and I'm pulmonary and critical care physician at Seoul National University Bundang Hospital. It's nice to meeting you through a Zoom meeting. First, I would like to thank for giving me this opportunity to present this interesting and challenging topic today. Also, I would like to appreciate Dr. Abdulaziz for our team to participate wonderful ASF ECMO study. The topic I'm going to cover today is antimicrobial dosing in special patient populations, patient with extracorporeal therapies. In extracorporeal therapies, large bore central venous catheters are needed to draw blood from a patient, process it in some way, and then return it to the patient. There is always a risk for catheter-related bloodstream infection, CLEPSI, as long as the central venous catheter is placed. Especially during ECMO therapies, once CLEPSI develops, microorganisms could be colonized in the membrane oxygenator, making treatment more difficult. The prevalence of hospital-acquired infection in patients running ECMO is known to be 21% in adult patients, which increases mortality by 40 to 60%. Also, most patients start CRRT or ECMO therapy because of infection, such as pneumonia or sepsis. However, CRRT and ECMO do not resolve underlying disease like an infection, but CRRT and ECMO maintain organ function until the underlying infection is resolved. Therefore, antimicrobial therapy is one of the most important treatments during ECMO or CRRT therapies. However, during extracorporeal therapies, the level of antimicrobial agents could be variable. Underdosing may lead to treatment failure. In contrast, overdosing could develop drug toxicity. Maintaining the optimal level of antimicrobial drug is correlated with good outcomes in patients with CRRT or ECMO therapy. So, in terms of critical ill patients undergoing extracorporeal therapies, there are three main factors affecting the drug levels. First, the underlying disease that patients are suffering from. In the case of sepsis, the capillary leak would increase the volume of distribution of drugs, lowering the drug level in plasma, especially for hydrophilic drugs. Also, kidney injury or hepatic injury will decrease the clearance of hydrophilic or lipophilic drugs, which increase drug levels in plasma. Second, the characteristic of the antimicrobial agents. Drugs level will increase or decrease depending on the characteristics of each antibiotics. Lastly, the main interest of today's talk is extracorporeal therapies. Drugs are could be sequestrated in extracorporeal circuits, and CRRT ECMO will increase the volume of distribution and alteration of drug clearance. Those things could be happen during the extracorporeal therapies. This well-organized table shows the potential impact of renal replacement therapy on pharmacokinetics of antimicrobials, which was published in Intensive Care Medicine last year by Dr. Abdul Aziz. You can see here blood flow rate, effluent flow rate, hemofilter pore size, those things which determined by patients, physicians, can affect the clearance of antibiotics level. For a patient with CRRT, drug clearance by CRRT should be considered. For ECMO, also ECMO influences antimicrobial kinetics by increasing the volume of distribution for a drug as well as possible binding to the or sequestration to the ECMO circuit. As a result, without any change of clearance, low plasma concentration is expected during ECMO. However, there are numerous factors affecting pharmacokinetics during ECMO therapy, patient factor, drug factor, or ECMO factor. And those numerous factors could change the pharmacokinetics, so antibiotics levels are not consistently increasing or decreasing during ECMO therapy. This results of pharmacokinetics in patients receiving ECMO, which was done in ASAP ECMO study published in Blue Journal last year, showed challenging antimicrobial dosing during ECMO therapy. In this study, antimicrobial PKs in this study they conclude antimicrobial PK pharmacokinetics were highly variable in critical ill patients receiving ECMO therapy, particularly piperacillin vancomycin, which leads to poor target attainment rates. Even during extracorporeal therapies, these kind of drugs, sedative, analgesic, and vasopressor, vasoactive agents can be adjusted according to the patient's clinical response. For example, the LAS score or mean artery pressure could be the parameter to titrate the dose of medications of sedative or vasopressor. However, regarding the antimicrobial agents, the clinical response generally takes at least 2 or 3 days, so antibiotics cannot be adjusted in real-time fashion like other medications, such as sedative or analgesic drugs. A potential solution to this dosing challenge during ECMO therapy or CRRT is therapeutic drug monitoring, so we call TDM. Several studies demonstrated that maintaining plasma antimicrobial concentration within the therapeutic range increases the likelihood of clinical efficacy while limiting the toxicity. This drug monitoring has been used to minimize the risk of toxicity, particularly in antimicrobials with very narrow therapeutic range, such as aminoglycoside and glycopeptides, vancomycin. However, recently, usage of this TDM has now expanded to ensure the therapeutic effectiveness. Another option for tackling dosing challenging is using dosing software, which may facilitate optimized antimicrobial therapy. Using the Bayesian forecasting model based on the TDM sample and the results with the patient-specific data such as renal function or weight, and this software provides PK parameter estimates and also the dosing recommendations. This is termed model informed precision dosing. In our hospital, we measure vancomycin plasma levels just before and 2 hours after administration. So, we measure trough level and peak levels, which made it possible to estimate this slope of decrement of the vancomycin level. And also, we put this two data, peak level and the trough level, into the software for estimating the pharmacokinetic parameters and recommended dose. So this software will provide the how to prescribe the dosage or the time interval. Those kind of things can be calculated by this software. And therapeutic drug monitoring of antimicrobial is recommended where possible, wherever possible, in critical ill patient treated with ECMO or CRT. However, TDM, except for glycopeptides, vancomycin and aminoglycosides, are not available in clinical practice in Korea. So, in Korea, in clinical practice, beta-lactams, fluoroquinolones, and linezolid, those kind of antibiotics cannot be measured in clinical practice. So, without those any TDM data, we could prescribe these kind of medications, drugs, antimicrobial agents, with the help of other results of other studies results. This is the population pharmacokinetic results of ASAP ECMO study, which are published in numerous journals. And these informations are really invaluable to us while prescribing those antimicrobials dosing during ECMO therapy or CRT therapy. And recently, Dolphin study or other studies published in intensive care medicine that beta-lactam or ciprofloxacin continuous TDM was not significantly reduced the hard outcomes in those studies. So for right now, we measure vancomycin or aminoglycoside TDM. In contrast, for other drugs, we use those kind of information to
Thank you, Dr. Sung Yoon.